Welcome to the American Diabetes Association's Diabetes Core Update podcast, where every month we review the most important articles in diabetes, obesity, and cardiometabolic disease. I'm Dr. Neil Skolnik, professor of family and community medicine at the Sidney Kimmel Medical College of Thomas Jefferson University, and joining me as always is my co-host.
Hi, I'm John Russell. I'm clinical professor of family and community medicine, also at Sidney Kimmel Medical College of Thomas Jefferson University.
And John, we have another great issue this month with some really practice-changing articles, beginning with one published in JAMA, evolocumab, to reduce the first major cardiovascular event in patients without known significant atherosclerosis and with diabetes. This is a sub-analysis, results from the Vesalius cardiovascular trial. Then we're going to talk about an article from the New England Journal on a related topic, that is, how low do you go, on intensive LDL cholesterol targeting and atherosclerotic cardiovascular diseases, looking at the benefits of very low levels of LDL being achieved. Then we're going to look at the cardiovascular outcomes with Tirzepetide compared with Dulag in patients with diabetes and cardiovascular disease, a post hoc analysis of the SURPASS CVOT randomized clinical trial, followed by an article from Diabetes Care on association between GLP-1 receptor agonists and ischemic optic neuropathy, a meta-analysis, and then a comparative effectiveness trial of Tirzepetide with Dulag or semaglutide on major cardiovascular events in type 2 diabetes and cardiovascular disease. These are insights from two target trial emulation studies, also published in Diabetes Care. And finally, we're going to finish with a presentation that was done that's not yet in publication, but presented at a major meeting on shingles vaccine and the reduction of cardiovascular risk. John, let's jump right in.
So, Neil, our first article is from JAMA and looked at evolocumab to reduce first major cardiovascular events in patients without known significant atherosclerosis and with diabetes. This was the Vesalius CV trial. So in this trial, it was a randomized double-blind placebo-controlled trial of evolocumab that was conducted across 774 sites in 33 countries, enrolled over 12,000 patients that did not have a prior myocardial infarction or stroke, had an LDL level that was 90 or greater, and qualifying atherosclerosis or high-risk diabetes. The pre-specified subgroup analysis examined outcome in patients without known significant atherosclerosis. So they had none of the following. They could not have prior arterial revascularization. They could not have arterial stenosis greater than or equal to 50%. They could not have a coronary artery calcium score of greater than or equal to 100 Agatston units. All of the patients had diabetes. Enrollment started in 2019, and the last patient visit was July of 25, with a median follow-up of 4.8 years. Patients were randomized in a 1-to-1 ratio to subcutaneous administration of either evolocumab, 140 milligrams every 2 weeks, or matching placebo added to optimally tolerated statin therapy. The predefined subgroup included 3,655 patients, 1,849 in the evolocumab group, 1,806 in the placebo. Patients had a median age of 65 years. 57% of them were female. Among them, those in the lipid substudy, the mean LDL level at 48 weeks was 52 milligrams per deciliter in the evolocumab group versus 111 milligrams per deciliter in the placebo group. A 3-point MACE event occurred in 83 patients in the evolocumab group for a 5% 5-year Kaplan-Meier estimate. And 117 patients were 7.1% on the same Kaplan-Meier in the placebo group, with a hazard ratio of 0.69. The between group difference was 2.1%. For the 4-point MACE, event occurred in 127 patients, for the 5-year Kaplan-Meier score being 7.6 in the evolocumab group, compared with 178 patients, with the 5-year Kaplan-Meier estimate of 10.5% in the placebo group, also having a hazard ratio of 0.69. The between group difference in this was 2.9%. There were 136 deaths. The 5-year Kaplan-Meier estimate 7.8% in the evolocumab group, compared with 172 deaths. The 5-year Kaplan-Meier estimate of 10.1% in the placebo group, with a hazard ratio of 0.76. Neil?
John, I love this trial. I've been waiting for this trial. But before I tell you why, let's just get the name of the trial out of the way. Vesalius, from Andreas Vesalius in Brussels in the early 1500s, who wrote the book on the fabric of the human body, which is the book that ushered in modern anatomy. The book was important because he also raised the issue of we need to question conventional knowledge by direct observation. Prior to this book and his work, everyone accepted what Galen from the 1st century CE had said about anatomy, but Galen got a lot wrong. Vesalius actually did human dissection. He wrote down in this book what he saw and essentially changed not just our understanding of anatomy, but our understanding of how to approach conventional knowledge and to look at it with honesty. And so it is not surprising that they named this trial after his name. Why do I love this trial? Well, we've known for years, since the Fourier trial and the Odyssey outcomes trial, that PCSK9s, when added to people who have existent ASCVD who are already on statins, leads to a much improved outcome. In my opinion, we underuse these medicines. They are recommended in the guidelines for high-risk people to try to achieve an LDL for a long time less than 70, now less than 55, and we underutilize them. That's in the highest risk group. But what the Vesalius trial did was it said, how about people who have not had a first event, who have not had an MI, who have not had a stroke? Is it still, in addition to a statin, as a PCSK9, in this case, ivolocumab, when added to that statin, going to have a benefit? Well, the first part of this trial, the main trial, which was published in the New England Journal, told us that yes, it is. Yes, they do. And the benefit is large. Now, this sub-analysis published in JAMA that you were just going over said, okay, in that large group, a lot of the people did have defined coronary disease. They had, as you mentioned, high calcium scores. How about the group that didn't even have defined underlying atherosclerotic disease, but were at high risk? People with diabetes, who had diabetes for a while, was the main group that we're looking at here. And sure enough, it's a big deal, big change in outcomes when you add evolocumab. There was a 2.1% decrease in 3-point MACE over 5 years, an absolute decrease, which translated to a 31% relative decrease. And when they further analyzed this, looking at the effect after you got that first year of treatment out of the way, that relative decrease was 41%. Is this going to affect our practice? I think it will. I think this is one of those major trials that's going to be at some point in the near future included in the guidelines, that for people with high-risk diabetes, for people with high calcium scores, that will be having the ability to consider, based on what I believe the guidelines will say based on this trial, the addition of a PCSK9 to achieve substantially better outcomes. Our next article from the New England Journal is on intensive LDL cholesterol lowering in atherosclerotic cardiovascular disease. This was an open-label superiority trial conducted in South Korea, where the authors randomly assigned patients with atherosclerotic cardiovascular disease in a 1-to-1 ratio to target LDL cholesterol levels of less than 55 milligrams per deciliter. This is the intensive targeted group, or less than 70 per deciliter, called the conventional targeted group. The primary endpoint was a composite of death from cardiovascular causes, non-fatal MI, non-fatal stroke, any revascularization, or hospitalization for unstable angina at up to 3 years. They also, of course, assessed safety. They looked at 3,048 patients who underwent randomization. The median follow-up was 3 years. The median LDL cholesterol level during the trial was 56 milligrams per deciliter in the intensive group, 66 in the conventional targeted group. A primary endpoint event occurred in 100 patients in the intensive targeted group, that is 6.6%, and 147 patients, that is 9.7%. In the conventional targeted group, that was a hazard ratio of 0.67, or to say it a different way, a 33% decrease in the primary endpoint with a p-value of 0.002. Safety was equivalent in both groups. John?
Neil, pretty interesting thing. And I think if you have to look to see what's going to change a lot in the care of cardiovascular disease for this year, I think it's going to be us reevaluating that how low do you go? And, you and I are old enough to remember that there were 130, 170 targets for LDL. And then some of the guidelines got away from that and just said someone should be on a high intensity or medium high intensity statin. And really, we didn't have those numbers as targets. And I think for a lot of reasons, I think for those of us who are doing primary care, I think it's really nice to have that number as a goal. And so I think we're going to see that back. But kind of interestingly enough, the old gold standard of 70, doesn't do as well as 55. And I think 55, is going to be our new kind of target really for our high risk patients. And I think that that's a good thing. Well, can you go too low? We need LDL to kind of make a lot of the hormones and a lot of the things our body uses. Well, going back to the late 60s, there were studies of the Kalahari Bushmen, or the now called the San people of Africa, who have LDLs in the 40s and certainly don't have any kind of misadventures because of that. Our children have very low LDLs, and their LDL rises. So there's not a whole lot of downside to that. Now, the study that you just talked about was one that someone was on their maximally dosed amount of statin that they could tolerate. And then you added on the PCSK9 to get down to this. So this is just looking at this number, a South Korean study. So I think what it should do is we really should be pushing that statin to, the best point that we can get it to. And, really, rosuvastatin is our most potent statin. And then depending on how far away we are, maybe we are going to have to reach to a PCSK9 to make it down to 55. Maybe we can just use ezetimibe, which is about $20 a month if you look at some of the discounted kind of pay for yourself prescriptions. So if you can really max out your most potent statin and you could use ezetimibe, maybe you can reach that 55. I think the other thing that I think is going to be a big question is, what do we do with the people who don't have a huge amount of kind of risk factors? Are we going to have even lower and lower thresholds to take someone who doesn't have these risks to put them on a statin? Because statistically, the exit door for most of us is going to be in the cardiovascular family. And when you look at soldiers who died during the Korean War who were in their early 20s, they had atherosclerosis on autopsy, some of them. So, do we wait until the plaque has built up to a point, and not everyone tolerates a statin super duper well. When you look at the statins trials, somewhere in that 8 to 10% of people have myalgias from that. But we're not necessarily exclusively kind of left with only one family to get us where we need to go. So I think we really should be re-looking at target numbers, and I think we should be using kind of the tools that we have, the many more tools that we have right now, to help us get to that destination. Our next article is from JAMA Cardiology, and it looked at cardiorenal outcomes with tirzepatide compared with dulaglutide in patients with diabetes and cardiovascular disease. This was a post hoc analysis of the SURPASS CVOT randomized clinical trial. So this was a parallel design double-blind trial that enrolled patients with diabetes and pre-existing cardiovascular disease between May of 2020 and June of 2022 at 640 centers in North and South America, Europe, Asia, and Oceania. The data was analyzed between July 25 and February of 26. Participants were randomized to receive either subcutaneous tirzepatide up to 15 milligrams or a fixed dose of dulaglutide, 1.5 milligrams administered weekly, with roughly about 6,500 people in both arms. The main outcome was a primary efficacy measure was time from randomization to first occurrence of a 6-point composite of cardiorenal adverse outcomes, including all-cause mortality, myocardial infarction, stroke, coronary revascularization, hospitalization for heart failure, and a composite of adverse kidney outcomes. Among the over 13,000 patients enrolled, the mean age was 64 years. There were 9,348 patients were male, 3,817 were female, 71% and 29% respectively. The mean standard deviation A1C was 8.4. After a median treatment duration of 46.9 months, the primary cardiorenal endpoint occurred in 1,559 tirzepatide treated patients, or 23.7%, and 1,803 of the dulaglutide treated patients, 27.4, with a hazard ratio of 0.84. Sensitivity analysis showed similar hazard ratio for narrower 5-component endpoints without the kidney composite outcomes of a hazard ratio of 0.86, and the 4-point composite component composite that lacked both either the kidney or heart failure endpoint also had a hazard ratio of 0.86. GI adverse events were more common with tirzepatide, 42.5%, than dulaglutide, 35.9%. Other adverse events were similar. Neil?
John, I just want to remind people about how important the SURPASS CVOT trial was, and then we'll talk about today's analysis. And SURPASS had a dilemma when it was being designed because the original CVOT trials, remember, were all based on non-inferiority. And so you can compare the active drug, either SGLT2s, GLP-1s, to standard of care, and you wanted to make sure that they weren't hurting anybody. But now it wouldn't be ethical to not use one of those medicines which have been shown to be superior to not using them in high-risk groups. So you can't run a new trial on a GLP-1 using a placebo comparator. So this was actually the first trial that addressed that dilemma using an active comparator. So tirzepatide was compared to dulaglutide because remember, dulaglutide had been shown in the REWIND trial to have beneficial cardiovascular outcomes. And so, this was really a groundbreaking trial in that respect. And the term imputed placebo, which most of us had not heard about before, came up with this trial because one could impute if tirzepatide is just as good, non-inferior as dulaglutide, then it too was better than placebo, as was dulaglutide. That was a lot of complexity, and it was done, and the trial was organized around 3-point MACE because that's what is needed for regulatory approval, and showing that it has cardiovascular benefit. But the reality of clinical care and what we've learned over the last few years is this interrelationship between cardiac and kidney and metabolic outcomes. So about 2.5 years ago, there was an American Heart Association presidential advisory called Cardio Kidney Metabolic Disease, a call to action, reminding us that of what we already know, but giving it a name, that all these different parts are actually closely linked in a cohesive whole. So what this analysis sought to do was look at that broader set of outcomes that included cardiac outcomes as well as kidney outcomes. And sure enough, when you look at that broad set of outcomes, Tirzepetide was significantly better, as you said, a 16% improvement on that multi-point MACE outcome when compared to dulaglutide, with a p-value that was very significant, less than 0.001. So how do we think about this? Well, on that 6-component cardiorenal endpoint analysis, there was an absolute risk reduction of 3.7% in the tirzepatide group compared to dulaglutide, and that turns out to equate to a number needed to treat to prevent one event, of number needed to treat of 1 to 27. One event is prevented for every 27 people treated. That's considered an excellent NNT. So what do we find from this trial? That on the broad array of endpoints, that dual agonist, GIP, GLP-1 antagonism, tirzepatide, performs better than dulaglutide. For our next article from Diabetes Care, we are going to look at the association between GLP-1 and ischemic optic neuropathy. This is a meta-analysis. Now, we've been talking about this a bit over the last year because this has come up as a bit of a surprise, I think, to many people, and it's important to be able to get the solid data and perspective on it. The objective of the authors was to investigate the association between GLP-1 receptor agonists and a non-arteritic ischemic optic neuropathy that is a form of optic neuropathy where there is sudden onset of visual loss in one eye, and it is not due to something like temporal arteritis, a arteritic cause of it. The authors looked at PubMed, Embase, and Cochrane Library databases. They calculated odds ratios and absolute risk for non-arteritic ischemic optic neuropathy, NAION, how I'll refer to it as we move on. They pooled those results. They also looked at any ocular event as a secondary outcome. They looked at 15 longitudinal studies. That was 8 trials with over 1.5 million patients included. GLP-1 use was associated with higher incidence of NAION risk with an odds ratio of 1.7, and that was fairly consistent across randomized trials, an odds ratio of 2.36, and non-randomized studies, an odds ratio of 1.6. Absolute NAION risk in the GLP-1 group was 0.09%. So even though we have that high odds ratios, the absolute risk was 0.09%, corresponding to a 0.037 risk difference, or number needed to harm of 2,700. There was no association with overall ocular events.
So, Neil, we've done some similar articles like this that have come to about the same conclusion. And, overall, if you look at the study, the amount of ocular events turned out to not be a whole lot different. But for our patients who are on GLP-1s who have diabetes, One can argue that that would lead to better glycemic control. Better glycemic control can decrease microvascular disease. So really a lot of the things that we're going to do to improve the care of someone's diabetes, uh, especially if it's early on, can have some implication in decreasing their vision loss from diabetes. So this is occurring in about 1 in 2,700 patients, kind of the number needed to harm. In my reading, for people who are not on a GLP-1, somewhere in that 1 to 10,000 in the general population. But, my concern for this is not necessarily our patients that we're trying to achieve better glycemic control. We're really the patients who are obese enough to be on one of these class of medicines for weight loss. I am worried that there are industries out there that are prescribing these medicines as almost cosmesis type things. And if I'm having a side effect that I lose vision from medicine I probably really didn't need, except for whatever reason that I went on to one of these online sites, that's a little bit worrisome. And I think that probably that needs to be in a bit of the disclosure, because that person with diabetes has a much higher rate of that, of losing vision if their diabetes is not in good control. But that person who doesn't have that risk and is just doing it for some cosmesis related thing, I am worried a little bit about this as a side effect that is not intuitively obvious. Our next article is from Diabetes Care, and it looked at comparative effectiveness of tirzepatide versus dulaglutide or semaglutide on major cardiovascular events in type 2 diabetes and cardiovascular disease. Insights from 2 target trial emulations. So the 2 target trial emulations included commercially insured adults between June of 2022 and December of 2024 who had type 2 diabetes and atherosclerotic cardiovascular disease. The patients initiated subcutaneous tirzepatide, dulaglutide, or semaglutide. The primary outcome was MACE, defined as a composite of non-fatal MI, non-fatal stroke, and all-cause death. First, new users of tirzepatide and dulaglutide were propensity score matched 1-to-1. Second, new users of tirzepatide and semaglutide were propensity score matched 1-to-1. Incident rates per 1,000 patient years and hazard ratios were estimated. After the matching, 9,233 pairs of tirzepatide or dulaglutide initiators and 25,206 pairs of tirzepatide or semaglutide initiators were identified. The tirzepatide initiators experienced a lower rate of modified MACE versus dulaglutide, an incident rate of 31.3 versus 39.4 respectively, or a hazard ratio of 0.8, which seemed to be driven by lower all-cause mortality among tirzepatide versus dulaglutide initiators with a hazard ratio of 0.6. In the post-hoc analysis, tirzepatide was associated with lower rates of pneumonia-related hospitalization when compared with dulaglutide. Rates of modified MACE were similar among tirzepatide and semaglutide initiators, 23.7 versus 23.2, with a hazard ratio of 1.03. Neil?
John, it's pretty amazing. We live in this time of enormous data sets, and this data set was from the Optum data set. Optum is essentially a company that aggregates information from multiple electronic health records, from from extremely large numbers of health systems and Medicare databases. And what it allows us to do is make comparisons like this, which really are needed between different medicines, which otherwise could only be done by an actual randomized trial. Randomized trials, of course, taking years and years and years, and often hundreds of millions of dollars to carry out. What this one shows is it confirms in a way what we would suspect, which is that people on tirzepatide being the dual agonist compared to dulaglutide, tirzepatide having both more powerful A1C reduction, larger metabolic benefits, and much greater weight loss than one would see with dulaglutide, that we see a lower incidence of MACE with tirzepatide versus dulaglutide. It's what we would expect to be the case, and it's nice to see that confirmed. That lower all-cause mortality, I'm not sure I would have assumed, and this was 40% lower. That's a big deal. And given that this is the best data on this issue out there, and it fits with what one logically would believe, and there are no obvious confounders that would otherwise explain this, uh, if all other things were equal, I think I would lean toward tirzepatide in that comparison if I were to pick a medicine for my patient. All things aren't always equal. We know that. The other thing, of course, that the trial showed is that tirzepatide and semaglutide came out about the same. Again, here, that is fascinating. These are both second generation, long acting GLP-1s, one, of course, a dual agonist, one, of course, a single agonist. Differences in both have excellent A1C reduction, excellent weight loss. Yes, there are differences in potency. This is what the data shows. And again, fascinating and the best data out there on the comparison. Our next article, John, is actually not an article, as we mentioned in the introduction, but this was a study that was presented at the American College of Cardiology's annual scientific sessions, and it looked at over 246,000 U.S. adults with underlying atherosclerotic heart disease, and its findings were so remarkable that we thought we would share this, even though it's not out yet in an article. Researchers used the TriNext database. Again, we've talked about these enormous data sets that we have out there. The previous one was from Optum. This is from TriNext. This is a data set that includes health records of millions of Americans. And they looked at, in this case, to assess the rate of serious cardiac events in people over age 50 with atherosclerotic disease between 2018 and 2025. The study included 123,000 people who had received at least one dose of either the Shingrix or Zostavax shingles vaccine, and the same number of people who had not received any doses of shingles vaccine. Demographic and other health conditions were similar between the two groups. When the researchers examined cardiac events occurring between 1 month and a year after shingles vaccination, and of course the same time period for unvaccinated individuals, they found that vaccination was associated with a lower risk across all outcomes studied. Vaccinated individuals were 46% less likely to suffer any major adverse cardiac event and 66% less likely to die from any cause. They were also 32% less likely to suffer a heart attack, 25% less likely to suffer a stroke, and 25% less likely to develop heart failure. John?
So, Neil, I think this is a very interesting study during these very interesting times when it comes to vaccines. So, I think when our patients are hearing all these kind of varying, different opinions, often not as rooted in science as the ACIP is kind of struggling to kind of find out what they are right now. Pretty powerful study. It's one of the interesting things that this study just really looked at a year. There was a study last year that really looked at up to 8 years and really found this kind of same thing. How do you kind of put this together? Well, if you look at influenza and you look at the 3 days after developing influenza, a study by McIntyre in the British Journal of Cardiology found that people have a tenfold chance of having a repeat, someone who's already had cardiovascular disease, a tenfold chance of having another MI, or a sevenfold chance of having a stroke. So really that acute inflammation is a really kind of big thing on this. And really shingles is an inflammatory response, kind of more local, but I think it's kind of fascinating. So there's, 1 out of 3 people over a certain age, probably over 60, are going to have shingles at least one time in their life. There's only about 100 deaths. The shingles vaccine itself, kind of a tougher vaccine in that it's very reactionary, and that people can, and it's a 2-dose series. There, the Zostavax was really kind of phased out before this trial really started. It really has mostly been the recombinant shingles vaccine, but it's only 100 people die from shingles. We're also starting to see studies with regard to decreasing dementia. Big study out of Kaiser Permanente, a big study out of Australia. And we're also starting to see things from some of the other adult vaccines that having less inflammation might be certainly is tethered to cardiovascular disease. So the anti-inflammatory certainly is tethered to cardiovascular disease, but we might find it tethered to a whole lot of diseases. And I think as we are struggling in the din of information to talk with our patients about getting some vaccines, I think this might be a potent one to talk about, hey, you are at risk for cardiovascular events. We probably all are over a certain age. That might be another reason to get the shingles vaccine or the flu vaccine. So I view this as a win for science.
For more information and links to the articles that we discussed in this issue, just go to diabetesjournal.org. Until next month, keep listening
And keep learning.